So, what are the drug therapies for obesity? Should we even have a drug therapy for obesity? And is it ever going to work? Because without retraining ourselves to behave differently, to gain a different relationship with food, to see physical exercise as a normal part of life, can we ever actually effectively address this obesity epidemic? So that's my first point. We already have a 100% effective method for treating obesity. It's just that we don't want to do it. And that's the part we have to overcome. We must start doing it. However, there are drugs available for obesity. You can imagine that drug companies would love to produce a very safe and effective anti-obesity drug, a weight loss drug, because you can imagine the amount of money that it would make a drug company. But in order to be legitimately marketed as a weight loss drug, it must be noticeably better than a placebo. And it must create a lasting weight loss, because we've got loads of things that produce short-term weight loss. And often the weight gain afterwards actually goes past the original level of obesity that the person started out with. So that's even worse. And it mustn't be dangerous. And, well, for people to keep taking it also mustn't produce even annoying or unpleasant side effects. Now, there have been a lot of drugs that have been marketed for weight loss and then have been withdrawn from the market because of the appearance of dangerous side effects. And so there aren't many available in Australia that are labelled for treating obesity. And none of them, well, there's only 2 of them we're going to talk about, but they should never be used as a single answer. And that all of the literature that you will see will say these are to be used along with diet and exercise. There isn't, and there will never be, in my view, a drug solution to a problem which is essentially a behavioural issue. So what have we currently got available? The drugs that have come and gone have fallen into one of these 2 areas. Either they've been trying to control your appetite, in which case they will tend to act in the brain, because in the hypothalamus is your appetite center, the place that tells you I'm hungry and I want to eat more, or conversely tells you you've had enough, don't think about food for a while. So the drugs that are trying to control appetite are one major area of weight loss drugs, and the other area is drugs that are trying to reduce the absorption of nutrients from the gut in the first place. So you've eaten 2 supersized Big Macs with chips and a thick shake because you couldn't stop yourself, but the drug will stop you absorbing all of the calories from those meals, and therefore you can eat yourself silly and not get fat. That's the idea of those types of drugs, whereas the drugs of the appetite controllers is that you aren't driven to eat so much or so often in the first place. Do they work? Not particularly well, but let's just have a look at the whole area of control of food intake. The control of feeding, as I'm sure you would recognize from your own personal experience, is incredibly complicated. It's incredibly complex, particularly in us humans, because eating is a behavior that is rewarded. It is rewarded by making it pleasurable for us to eat. We love the look of food, we love the smell of food, we love the taste of food, we love the whole experience of food. It has a big social component to it for us humans. We bond over food, we get together over food, we talk about food, we think about food, we advertise food, dress it up, make it look good. Look at the number of programs that deal with cooking of food, making food sexy and having sexy people making food. And food plays a huge role in many aspects of our lives, and it's a very rewarding part of our life. So there are a lot of positive reinforcers for us to eat, particularly to eat yummy food. And all of those things, the taste of food, the better it tastes, the better it smells, the better it looks, and our views on food and all of our experience of food and what we think about food will all increase the reward that we get from food, and therefore will tend to increase the amount of food that we eat. At the same time, when we do eat, There are signals that come from the gastrointestinal tract, particularly from the stomach, saying, okay, they've had a stomach full, that's enough, you don't need to have any more, this will keep us going for a good day. The stretch of the stomach feeds back and gives you a feeling of satiety. In other words, a feeling of satisfaction, a feeling of fullness, feeds back into your brain and tells you, okay, we're full. So that would reduce your desire to eat anything else for quite some time. So that should feed back negatively on food intake. But more recently, there have been a number of hormones discovered which are made by adipose tissue. They are released exclusively from adipose tissue, and therefore they are released in greater amounts the more adipose tissue you have. And these signals are actually to increase your feeling of fullness or satisfaction, and they act also to decrease the rewardingness of all of these experiences of food. So the increased level of these hormones such as leptin and adiponectin, which derive from adipose tissue, is exactly as you'd expect it to be. Their influence is that they should stop you wanting to eat so much. And it makes perfect sense that they should do that, because the more fat you have, the less reason you have to need to eat. And so if the regulatory system is working, then these signals should tend to reduce your desire to eat. And there are more than just these two. There are a number of signaling chemicals which are released from various places, not just adipose tissue, which are designed to reduce your desire to eat and therefore to regulate your food intake. We know that with leptin, for example, the more fat that you have, the higher your leptin levels should be, and therefore the greater the inhibition of eating should be. And in fact, we know that in people who are deficient in leptin, tend to become extremely overweight. And if you replace the leptin, then they return to normal weight, because the leptin seems to do its thing, which is reduce the desire to eat, and it works perfectly. But what seems to happen with the majority of people as we become obese, we become resistant to the effects of leptin. So although there are high levels of leptin around, we're not responding to them anymore. And so at least that component of our food intake regulation has started to go nuts. Now, it could be that if we exceed a certain level of fat accumulation on our bodies, then our regulatory systems start to break down in the same way that we've seen with insulin resistance coming around. You know, if you increase your plasma glucose levels and keep it high for a long period of time, then your ability to regulate that blood glucose starts to break down, because you're no longer dealing with a healthy system. So that is one possibility as we become obese and remain obese. So it's a very complicated mix of factors, as we would all know and understand, being all of us people who eat and who don't exercise. Probably most of us don't exercise enough, and probably most of us eat a little bit too much because we have such abundant and yummy food available to us. Okay, so let's look at the two drugs that are actually available in Australia as weight loss drugs. The first one is this one, phentermine, and this is one that acts to suppress appetite. That's the idea of it. It is an amphetamine. And amphetamines all have a stimulant effect on the central nervous system, and the way that they do that is they release monoamines in the central nervous system. So they release noradrenaline and serotonin in the central nervous system, and therefore they increase the functions of those neurotransmitters, and they have a stimulatory effect that way. So they'll tend to wake you up. They'll make you more active. And as you will know from your own experience, if you're more active and busy, and also if you're slightly more anxious, if you're more alert and you've got a greater sympathetic drive, you tend to think less about eating. And so whether they directly suppress the appetite or whether they simply make you slightly anxious, slightly under sympathetic drive, and therefore thinking less about things like eating, it's not known. But they can have an anorectic effect. In other words, they can reduce people's food intake. But there's a high price to be paid for that in terms of adverse effects. they will have all the effects that you would expect them to have, given that they increase the release of monoamines in the central nervous system. So, tachycardia, increased blood pressure, irritability, anxiety, insomnia, dry mouth, the list goes on. Anything that you would associate with increased sympathetic drive, increased stimulation of the central nervous system, they could potentially produce. They are also addictive because they have an effect on mood. They can produce a sort of feeling of well-being, euphoria, which can produce a psychological dependence on the drugs. So a high price to pay for suppression of appetite. But that is a drug that is available, and there are a whole list of warnings of people who couldn't have the drug. For example, anybody with any problems with high blood pressure or cardiovascular system, or any problems with any systems really, it would be unwise for them to have the drug. But also it would be unwise for anyone to try to rely on this as the sole point of attack against obesity. That would have to be used along with an exercise program and along with a calorie restriction program. The second drug is orlistat. Orlistat operates in the second way that we talked about, and that is it inhibits lipases, the enzymes that break down fats. It inhibits the gastric lipases, it inhibits the pancreatic lipases, and it inhibits intestinal lipases. So it inhibits fat breakdown at all points in the gut where fat breakdown normally occurs. The result being that if you've had a fatty meal, a large proportion of the fats in that meal will not be digested and therefore will not be absorbed. So they won't add to your calorie burden. That's a good thing. They never get into the bloodstream. However, they do remain in the gut and they pass on through the small intestine, undigested and unabsorbed, and into the large intestine where you have bacteria who can't believe their luck really that all of these marvelous fats are coming through to their end of things, and so they get to work on the fats and produce large amounts of gas, and they break down the fats into smaller components, and it's marvelous for them. But it means, of course, that the adverse effects of this drug are flatulence, diarrhea, fecal urgency, so often you'd have to rush to the toilet at inopportune moments because your feces would be much more watery as a result of all of those additional solutes in the forms of those fats and triglycerides that have got down into your large intestine. The large intestine, of course, is the place where normally you get the removal of water from the contents of the gut, and so that they get drier and harder. But with the presence of all those solutes still in the gut contents, then that won't happen, so you'll tend to keep the contents of the bowel quite watery and therefore maintain a sort of constant diarrhea-like state, along with the additional gas that will be created by the work of the bacteria down there. So not the best in terms of adverse effects, can be pretty embarrassing if you're on orlistat, but combined with other methods it may help in weight loss, and certainly in people who are obese or seriously obese you have to try everything you possibly can. It might be particularly effective if you use it along with metformin in people who already have type 2 diabetes. So it would be probably at its best in combination with metformin and also behavioral changes. So that's the picture as far as obesity and metabolic syndrome go. It's an important public health issue, and it's something that you really do need to have your head around and to understand a little bit of the complexities of it, and also just how far pharmacological management can help in the problem. Okay.